Okay, here's chapter 27, chest and abdominal trauma. So getting into the beginning here, let's first talk about the impact of trauma to the thoracic cavity. Think about the organs that are contained within there. Not only do we have the lungs and the heart, but we also have some major vessels, and we also have the spinal cord that's running through there. Injuries to the thoracic trauma or to the thoracic region are oftentimes very, very deadly, and we need to be able to quickly identify these and, more importantly, treat them as soon as we can identify. So looking at the slides here, blunt trauma, obviously with our ribs, broken rib, it's painful, it hurts, not the end of the world. But what happens when that broken rib ends up penetrating the lung? Or more so than anything, think about the principles of physics, and if energy impacts the chest to the extent that it breaks a rib, then what type of energy is delivered beyond that point to the heart or to the lungs themselves? We have the potential for pericardial bruising. We also have the potential for pneumothorax, which we'll get into more in this chapter. With compression injuries, all the air that is stored within the chest, as the chest becomes compressed rapidly from an outside force, that air is pushed out. In addition to the air being pushed out and somebody feeling like they've had the wind knocked out of them, I would say that's a mild way of describing it. A lot of the blood that sits in the thoracic cavity is pushed to other areas of the body. And with those compression injuries, we can start to see things like the head turns very red. We start to see a lot of swelling and bulging because of the immense amount of pressure that's forced up into the cranium from the thoracic cavity. We also have penetrating injuries that we have to be concerned about. Anytime we have a penetrating injury, we again want to know what could be involved. Penetrating injury to the abdomen, while it certainly could be serious and life-threatening, generally speaking, the abdomen has a lot of non-vital organs within it. A simple stab wound to the middle of the stomach, or even a gunshot wound for that matter, is likely just going to impact the small intestine. However, any type of penetrating trauma to the thoracic cavity, we have the potential again for those large vessels, spinal cord, the heart, the lungs, etc. So looking first of all at closed chest injuries. Here's a great view of what the thoracic cavity looks like from the spinal or from the skeletal perspective. And assuming that the skin over the injury site here is still intact, what ends up happening is some amount of blunt force trauma. Maybe it's a car accident hitting the steering wheel, maybe it's a baseball bat, you name it, ends up breaking a handful of ribs. And anytime we have two or more ribs broken in two or more places, it's considered to be a flail segment. So in this case here, you see we have multiple breaks and they're contiguous. We have more than two breaks and it's in more than two places. So as a result, it's going to be considered a flail segment. The downside to this is the intercostal muscle that runs inside of the ribs there. It is not effective in expanding the rib cage. Remember that as we inhale, that's an active process, and that requires the contraction of those intercostal muscles. If the ribs themselves, if the bone here is fractured off, it does not allow for the rib cage to expand on that side, and as a result, we have not only pain, but also decreased tidal volume with each inspiration. The other thing I want you guys to pay attention to is you see how areas of the ribs are shaded lighter than over here. This represents the cartilage. So the actual bone itself circles around to the front and then it stops, it terminates. And then we have the cartilage here. Think about when you do CPR, you're placing your hands over the middle of the sternum, you're compressing over the sternum here. And as a result, when we feel that popping or cracking sound with compressions, we're actually breaking this cartilage right here. So another great example, and I've got a video coming up in just a second that will show it. Paradoxical motion here, which is the term that we use to describe unequal motion or opposite motion, is actually not very prominent. We have to look for it. And that requires a good comprehensive assessment when we're doing our head to toe. And it further supports the need for us to expose our patients when we're doing trauma assessments. If I have a patient that's incurred enough trauma that there's a flail segment here, I should have them stripped down to their underwear at most, if not fully nude, so that I can catch these subtle types of injuries. So let's watch a video here that represents a flail chest with paradoxical motion. So it's pretty easy to see where the trauma is, right? You've got some trauma to the chest here. And I want you to watch. See that real subtle movement there? Obviously, if he's got pain and discomfort, then he's not going to be taking deep breaths. This guy's trying to take shallow breaths. It hurts. And as a result, it's not going to be very clear or easy to see. But continue to watch right along in here. You see that there? See how it's drawn in and out, just this little section here? That's your paradoxical motion. That's how subtle it might be. This guy here probably has a couple ribs that are broken, and it's more than likely a result of some type of blunt force trauma from the road rash on there. My guess would be he was thrown from a motorcycle or something like that. So moving on to our patient assessment as a whole with the thoracic cavity. Anything respiratory wise and anything that has to do with cardiac output, those are things that we'd want to be looking for as it relates to the thoracic cavity. Obviously, difficulty breathing would be something that we'd have to be concerned about with not only that flail segment that we just talked about, but with the pneumothorax and hemothorax that we'll be talking about in a few minutes. Any complaints of pain, take your time. Do your rapid trauma assessment, identify those life threats and fix them, but then we want to go back through right away, and we want to really take our time. Listen to lung sounds in maybe 5, 6, 7, 8 places. Really take your time to listen, do a good hands-on assessment, touch every square inch of the thoracic cavity there, and we might be able to identify areas of flail segments. We might be able to identify crepitus, which is going to be air underneath the skin. That would support the possibility of a pneumothorax, etc., etc. With our trauma patients as a whole, we've talked a lot about in the past titrating oxygen, not over-delivering oxygen, that type of stuff. It's really important not to necessarily understand when to titrate, but why we titrate. And remember that the reason we titrate is because we don't want to give too much oxygen to patients who have organs that are already damaged. Therefore, if the patient is experiencing a heart attack, those cardiac cells are damaged, we don't want to introduce too much oxygen to the point we're creating free radicals, and those free radicals attack the already damaged tissue. In this case here, though, with trauma, we have widespread systemic issues with perfusion. Anytime we start to bleed out or we experience trauma that reduces cardiac output, all parts of the body are affected. And what we want to do is go ahead and try to give as much oxygen as we can to the point that it makes sense. If your SATs are slightly above 94, 95 for your patient, excuse me, it's not the end of the world. We really need to be sure that our trauma patients are well oxygenated. We know that with any patient, if they're breathing inadequately, we want to assist those ventilations. Consider their mental status. We may not be able to ventilate a patient who is conscious, awake, and talking. If they become altered, lethargic, semi-conscious, and they will tolerate it, then you may need to go ahead and begin ventilating your patient. But your assessment here is really no different than it would be with your medical patients. Identify potential injuries, identify the needs for the patient, treat their signs and symptoms, and then work on trying to find underlying causes for their presentation. The great thing about trauma versus medical is that trauma a lot of times will present with outward signs of what's going on. You might have physical indications on the body as to here's the problem that the patient has and here's what I need to fix. For instance, if a patient is hypotensive and they are semi-conscious and they have an arterial bleed, well, it's pretty easy to identify that they're probably bleeding out, and if we stop the bleed, we fix the problem. Whereas with our medical patients, we can't necessarily identify the appendicitis or even a AAA for that matter. So these things should be a little bit easier for us to treat. When we are looking at open chest wounds, entrance wounds and exit wounds are really important, especially with a gunshot wound. The entrance wound is typically going to be relatively small, not much larger than the size of the bullet going into the body. And because of the speed and the heat that's generated from it, it almost cauterizes the wounds as it makes the entrance there. You're going to typically have very little bleeding from the entrance wound. However, identifying an exit wound is going to be the biggest thing here. The exit wounds typically have, they're significantly larger than the entrance wounds. They're not cauterized, they bleed. So if I have a patient that's shot in the front of the chest, I should be focusing on rolling them, doing a log roll and assessing their back and looking for that exit wound off the back side there. That's probably where I'm going to need to be doing a lot of bleeding control, and I'm going to need to put an occlusive dressing on the back side just like I am on the front side. So our sucking chest wound is caused from a penetrating injury. If the skin on the chest is broken and it also puts a hole into the lung. So picture that, right? I get shot into the chest, bullet pierces through the skin, then it also pierces into the lung. I now have the inside of my lung that is exposed to the outside air through that hole in my chest. When we think about the principles of inspiration and expiration, we know it's all about pressure. And we have to ensure that as we inhale, the pressure decreases in the chest. That allows all the air outside to rush in through the trachea, down through the bronchi, and into the alveoli. And then as I exhale, it increases pressure inside the chest, forcing all that excess air out, and then I repeat the cycle. Anytime, though, that I have more than one opening, and that's what's caused with a penetrating chest trauma, I can no longer maintain those balances of pressure. So the sucking chest wound, as I inhale, and I should be decreasing the pressure in my chest, well, what all of a sudden happens is that air rushes in through that hole. And with that, it prevents that lung from actually expanding and doing its job. So what ends up happening is that lung begins to collapse. The way we fix that is we plug the hole. Now we need to be sure that we use airtight dressings here. I can't simply put a standard dressing, gauze pad, cling, something like that over this injury. I need to be sure it's airtight. We have commercial occlusive dressings that we can use now, different types of chest seals. Those are typically provided to most EMS agencies, but we can also think outside of the box. And especially if we're working in a mass casualty situation where we're limited with our basic commercial supplies, what else do we have that can work? So for instance, we could take a 4x4 piece of gauze. We could get some of the lubricant that we would normally use for our nasopharyngeal airways. We smear that lubricant on the 4x4 piece of gauze. Once we do that, and as long as we spread it out nice and thin, that becomes an airtight barrier. I can now put that piece of gauze over the entrance wound to this bullet wound, or even a stab wound for that matter, and then I begin to tape it down. That gives me an airtight seal. Even better than that, I can take any type of plastic pad that I have, and as long as I tape it on all sides, it's going to create that seal. So for instance, could we think about, could we use an AED pad? Take cardiac arrest out of it. Could I take the pad of an AED and use that adhesive and apply it directly over an entrance wound and use that as an occlusive dressing? And the answer is absolutely yes. You certainly could do that. That's a very expensive way of dressing that wound, but if that's all we have to work with, that'll certainly do the trick. Anytime that we have any type of injury, and really we've seen, maintain the airway, provide oxygen as needed, monitor ABCs. That's a repetitive theme in every single chapter for every single patient presentation. So that shouldn't be anything new to you. But beyond that, applying these new things, right? The occlusive dressing, the high concentration oxygen, caring for shock here. If I have a penetrating chest injury with a collapsed lung, a pneumothorax, what else is involved? Did it hit the subclavian artery? Did it hit the aorta? Did it hit the superior vena cava? Am I bleeding out into the chest? Is it not only a pneumothorax, but is it also a hemothorax? These are all things that I need to be assessing for and ultimately treating for. Anybody with a penetrating chest injury, I think it's common sense that it's going to be an ALS response. If ALS service isn't available to you, then obviously rapid transport. And with any trauma, we know that our scene time should be 10 minutes or less, unless for some reason we cannot extricate the patient from a vehicle, from a building, whatever. But if you have the ability to transport in less than 10 minutes, you better be out of there in less than 10 minutes. All of your interventions should be done in the back of a moving ambulance, from your vital signs to your wound dressing and everything else. Rapid transport to a trauma center is going to be the most important thing for these patients. So occlusive dressing, we talked about the different commercial ones. We said that we could use an AED pad, or we could take a 4x4 piece of gauze with lubrication on it, and that would all work too. As we apply those, we want to be able to tape them down and make sure that air isn't getting in. As the patient inhales, it should suck that dressing flush or tight against the wound itself and prevent air from getting in. Some of these are designed with Flutter-Valve, so as the patient exhales, what it'll do is it'll actually have a little, almost a little like pathway through the dressing that allows air to escape. Won't allow air in, but it allows air to escape, and that slows the process of the lung collapse. But not everything we do will have that available. So in the instance of using a non-traditional device to try to accomplish this, we may actually have to pull that bandage back a little bit, and it's called burping the wound. As they begin to show signs of a tension pneumothorax, which we'll hit in a few minutes here, that tells me that, okay, my occlusive dressing is doing its job. That's phenomenal. But now I have side effects from it. So I need to fix those side effects. So I would pull that dressing back. I would burp it as they are exhaling. And then as soon as they're done exhaling, I would quick slap it back on and reseal it up. That's something that you may have to do every 2 to 3 minutes, maybe every 15 to 20 minutes. It depends on how severe of a hole there is in the lung itself. But we need to continually monitor our patients for those changes. So here's a great example, right? As they breathe in, it sucks the seal against the wound there, does not allow air out. As they exhale, that's the purpose of leaving this corner open. The theory is it would push the air as they exhale out the wound, and then it will come out through that corner. However, that really is not effective. The commercial devices have a channel that pushes air out that way where there's no adhesive, and they work relatively well. But even with the commercial devices with those vent ports in there, we still need to monitor our patient for the pneumothorax, the tension pneumothorax rather, and burp these dressings as the need arises. All right. So now we're getting into the specifics for these thoracic injuries. And as you guys recall, every time I've talked to you about this type of stuff, when we do head to toe, as a first responder, if you said I'm looking for decap BTLS, that's fine, no problem. However, as we're getting into EMT, I don't want to hear decap BTLS. You need to know what it is, you need to know what it stands for, and you need to be running that through your head as you do your assessments. But when I ask you, what is it that you're looking for in the chest? I want to hear you say, I'm looking for signs of a pneumo or hemothorax. I'm looking for indications of a cardiac tamponade, those types of things. You need to be able to identify specific injuries and how to treat them. So talking about pneumothorax, going back to medical in the respiratory chapter, we said that somebody can develop a spontaneous pneumothorax. Those tall, thin smokers, because their lung elasticity is reduced, if they have a good cough, they could pop a small hole in their lung. I've treated kids with spontaneous pneumothoraxes. A pneumothorax alone is not life-threatening. And a lot of times, especially with the spontaneous pneumo, the treatment is rest, take it easy, and do nothing. Let it heal itself. The patient might stay a day in the hospital, maybe. They might be on low oxygen levels or low oxygen concentration during that time, but most of the time it's go home, I want you to rest, and let it heal. However, if that simple pneumothorax develops and it continues to get worse faster than it heals, then eventually pressure is going to build up in the chest. Once the pressure builds up on the side of the chest where that wound is, the pressure builds on the outside of the lung itself, inside of the chest wall. So underneath the ribs, underneath the skin, but outside of the lung. And that little space in there called the pleural space, it becomes larger, larger, and larger as that lung begins to collapse. Naturally, as the lung collapses, we have reduced tidal volume, shortness of breath, and decreased cardiac output. The reason we have that decreased cardiac output with the tension pneumothorax is look here now. So air, and this shows an open pneumo, but whether or not it's an open or closed, it doesn't matter. As air continues to develop outside or inside the chest wall, but outside the lung, it collapses this lung. As the pressure builds up on this entire side, then things end up pushing off this direction. And the heart sits. If we're looking at the patient, right, we know that the heart is going to be sitting kind of right off center in this area right here. That pressure begins to push the heart kind of rotates and kinks off, and that superior vena cava is not very strong. So it kinks off that vena cava. It reduces blood return to the heart. If we have less blood in, we have less blood out. So indications of a tension pneumothorax would include things like jugular vein distension. That heart gets pushed off to the side, it kinks off the vena cava, blood backs up, and we start to see the jugular veins in the neck become engorged. So JVD is a big sign. A drop in blood pressure. So if they become hypotensive, that's a big indication. Again, less blood in means less blood out. We're going to see that with their blood pressure then. And then obviously, if we were to listen to lung sounds on the affected side here, we would have either decreased or absent lung sounds. It would be very, very shallow at best. The patient's also going to complain of pain over to this side. They're going to complain of shortness of breath. And there's one thing that you guys will see on the exam, and it talks about percussion. And percussion is not something that we typically do in the field because it requires utter silence in order to do effectively. And it's not a very decisive assessment, I guess you could say. But understand that when it does talk about percussion, and it is on the exam, percussion means that if I were to tap against this side of the chest wall here, would it sound hollow or would it sound solid? And obviously, if I have a substantial amount of air built up right in here, it's going to sound hollow. Think about knocking on a concrete floor versus knocking on a hollow drywall wall. Right? It has air behind it. The other one is a solid mass. If it is a solid mass, it's going to be dull to percussion or hyporesonant. Dull to percussion or hyporesonant. If it has less mass with air behind it, it's going to become hyperresonant, or it's going to sound kind of hollow. So if it has air trapped behind it, as it would with a tension pneumothorax, it would be hyperresonant, and it would sound kind of hollow then. Make sure you've got notes on that. All right, moving on to hemothorax now. So if we look at the root word for pneumothorax, it's pneumo. Pneumo means air. And think about pneumatic tools and stuff like that. Those are all tools that are powered with air. Now we go on to hemo, right? The root word for the root word hemo is blood. So in this case, we have blood in the chest versus here we have air in the chest. Pneumothorax, air in the chest. Hemothorax, blood in the chest. Notice here we can also have a hemopneumothorax. And in most cases, if we have that type of injury to the chest, it will be a hemopneumothorax. The injury is going to cause some amount of bleeding. The blood typically will settle in the lower lobes, just like fluid does with congestive heart failure. So if I were to percuss or listen to lung sounds in the lower lobes, it would be dull to percussion. It would be hyporesonant, and it would also be I would probably hear zero lung sounds whatsoever because of the fluid that's in there, and it's relatively dense. Pure blood is obviously much more dense than that frothy sputum or frothy fluid that we develop from congestive heart failure. If I were then to listen to lung sounds or percuss the upper lobes, I would expect them to be hyperresonant. It would sound somewhat hollow. Lung sounds would still be diminished because the lung is collapsed, but I might at least have a chance of hearing something in the upper lobes there. So here's some great examples. Pneumothorax, strictly air. Hemothorax, strictly blood. Hemopneumo, and again, this is most likely what we'd run into, is a combination of both. If you guys have ever watched any of the reality TV shows with ERs and trauma centers, you'll see one of the first things they do is they put a chest tube in. And they put that chest tube in, usually in the lower ribs along the lateral side there. And what that does is it allows this blood to drain out. And once the blood drains out, it also allows the air to begin to escape. But once that chest tube is in place, that's really a temporary fix, right? Even after we remove all this air and remove all this blood, it still takes time for this lung to reinflate. And we haven't fixed the bleed yet. So the priority for this patient in the hospital is going to be to get to the OR so that they can open up the chest, find the source of the bleed, and stop it. Now moving into traumatic asphyxia. This type of thing is something we can run into. We've seen it with somebody gets pinned between two cars, right? The chest gets pinned, a forklift against the wall, somebody gets pinned in there, or even something gets dropped on their chest. Any of these situations where the chest itself becomes compressed, then we have the potential for traumatic asphyxia. And what ends up happening, as the slide shows you there, is that the blood itself gets forced out of the thoracic cavity because of that compression. Think about when we do CPR, right? That's an external compression on the heart itself, and we're doing that for the purpose of pushing blood out of the heart to continue to circulate it. Now, the upside is that blood should flow back into the heart once we release that compression. With something like a traumatic compression, though, of the chest, we don't have that immediate blood return. So the blood is forced out of the thoracic cavity, and a lot of times it's going to be pushed straight up into the head. It's the path of least resistance. Think about the aortic arch as the aorta exits the heart, and then think about how the carotid arteries branch straight off that. That's going to be our path of least resistance. So think about what the head might present with in that circumstance. Eyes might look bulged out, might have a lot of eyes would certainly be bloodshot. We'd have capillary ruptures. We'd have bruising to the head. The head typically presents red or purple, and the patient obviously would have the potential for stroke, aneurysm. They would likely be unconscious, but if not, complaints of headaches and stuff like that. Cardiac tamponade. Now, this is an interesting one. This doesn't happen often. And it's very difficult to identify and especially fix pre-hospital. With a cardiac tamponade, similar to what we're talking about with the hemothorax, there's some source of bleeding from the heart muscle itself. And around the outside of the heart muscle is something called the pericardial sac. So imagine a potato sack. I'm sure as kids you guys did potato sack races. Think about how all those fibers are kind of cross-hatched in there or woven together, and how thick and fibrous it is. The pericardial sac is something similar to that. Very thick, very fibrous, doesn't tear, break, or rupture. So if I were to cause a blunt force trauma over the sternum there, let's say that I'm playing baseball and I take a pitch straight to the center of the chest. If that force, if that energy transfers through and actually impacts the heart and causes one of the blood vessels around the outside of the heart muscle to rupture, now we have bleeding. That bleeding stays contained within the pericardial sac. So as things continue to happen, that pericardial sac doesn't expand. It does not get any larger. The only thing that happens is that pressure applies downward on the heart muscle, and it prevents the heart from expanding. Now, while the heart doesn't necessarily collapse, it is a similar circumstance to that of a pneumo or a hemothorax, where the lung is unable to expand. Now the heart is unable to expand. We have decreased cardiac output as a result, and over time, that could certainly lead to death as the pressure gets larger and larger on the heart itself. When we're assessing for this, we have to think about what actually happens. So if the heart is unable to expand and take as much blood in, think about the physical presentations. That means blood gets backed up. And anytime blood gets backed up, we look for it in the neck and the source of JVD, jugular vein distension. The other thing we can look for is less blood in means less blood out. Do they have a decreased blood pressure? So they're probably going to be shocky. Now here's something that's kind of unique. We're looking for a narrowed pulse pressure. Narrowed pulse pressure is something that we identify with the blood pressure. So a normal blood pressure for an adult, 120/80, right? That's a 40-point difference. 120 minus 80 is 40. So there's a 40-point gap between systolic and diastolic pressures under normal circumstances. And we know that can vary a little bit either way, but generally we're going to be in that ballpark. With a pericardial tamponade, we don't have any issues with vasoconstriction. Everything is still working fine. The only problem we have is with the heart's ability to pump out. So that means that the diastolic pressure is still going to be normal. That systemic vascular resistance, which is really controlled by vasodilation, is a fixed thing. It doesn't drop all that much because the blood vessels remain constricted. So what does end up happening, though, is the heart's ability, specifically the left ventricle, the ability for the left ventricle to pump out and overcome that diastolic pressure or that systemic vascular resistance becomes more and more difficult over time. So we'll start to see a drop in blood pressure, and let's say that we start at 120/80. The next one we might see is going to be 110/76, and then all of a sudden we see 100/70, and then now we're at 90/68, right? And the difference between 90 and 68 is 22 points. So we started with a 40-point difference between systolic and diastolic. And now we're down to a 22-point difference between systolic and diastolic. And that's something that we would notice by trending. A single blood pressure alone isn't enough to tell us that. But if we have a couple, 2, 3, 4 vitals that we can trend, and we see that pulse pressure narrowing gradually over time, that's going to be a big indicator for our pericardial tamponade. So again, narrowing pulse pressures, hypotension, JVD, those are going to be 3 big things that we're looking for with the pericardial tamponade. Aortic injuries. Aortic dissection is something that, think back to your car accidents, right? We said that there's 3 impacts when there's an incident. You have the vehicle impacting another object, you have your body impacting the vehicle, and then you have your internal organs impacting your body. Same thing applies for the aorta. Now, while the aorta is not loose and floating in the body like some of your other organs are, it is attached to the spinal cord by some fibers. And as you suddenly stop, you come to that abrupt stop, the law of inertia maintains everything else moving forward. That aorta has the potential to tear away from the spinal cord itself. All right, and I said spinal cord, not the spinal cord, but from the spine, from the spinal processes. And then what ends up happening then is that it tears itself away. We have the potential for bleeding there, and we would refer to that as an aortic dissection. Different from an aneurysm in the fact that it's not due to a weakening of the vessel wall. It doesn't burst, but rather it simply tears itself open as a result of the trauma itself. You guys can imagine complaint of a tearing chest pain would associate with this. In addition to that, if the patient's even alive when they get to you, depending on the significance of the tear, they're probably going to look pale, sweaty, diaphoretic, showing all the signs of shock, hypotensive, etc. Nothing that we can really do to assess internally other than, okay, they're showing signs of shock, mechanism of injury supports this, and they complain of a tearing chest pain. We're going to have to treat this as a potential aortic dissection. And the only fix for this is getting onto the OR table as soon as possible, opening up the chest, and trying to stop that bleed. There's everything we just hit on, so that's good. Commotio cordis. All right. If you guys have ever participated in like a Little League event or most sporting events really nowadays, you'll notice that AEDs are a requirement everywhere. When I used to be on the Little League board and when I used to umpire for Little League when I was much younger, it was not something that we ever thought about. We had a first aid kit, a few bandages, a couple ice packs, but that's it. It wasn't until probably close to the year 2000, give or take, that AEDs started to A, become more available, B, they started to become slightly more affordable. But even back then, they were several $1,000s a piece. But there was a case study of a Little League player who took a pitch to the chest. This was a healthy boy. He had no past medical history, no cardiac issues whatsoever, simply took a pitch to the chest. And if you think back to cardiac, when we talked about the different rhythms there is a slight period of time where the heart is vulnerable. And it's as as everything is resetting and preparing for the next contraction, it has that period of vulnerability. It is literally a fraction of a second. But if the heart is impacted with enough force at that very, very small period of time, it'll actually throw the heart into VFib. And that's what happened to this little league kid. He took the pitch to the chest, threw him into VFib. He died right there on the field. This is obviously a fixable cause, right? VFib, we know that we can fix that with a defibrillation. Had there been an AED readily available for this otherwise healthy kid with no cardiac history, they probably would have been successful in shocking him back into a perfusing rhythm pretty quickly, and it would have more than likely had a positive outcome. So in this case here, if we respond especially to a sporting event, it could be a spear tackle in football, for instance. It could simply be two softball players colliding on the field. You name it, it's potential. If we respond to somebody who is in cardiac arrest, a sudden cardiac arrest, without any apparent trauma to really support it, and they have no significant medical history, there's the potential that that's what this is. We're not going to know. We're not going to have any idea what it is. We're going to get called out for cardiac arrest. You're going to get there. You're going to begin compressions, and you're going to get the AED on them right away. The potential for success with this patient is similar to other cardiac arrest patients in that every second that goes by decreases the chances of survival. So be sure that you get there, get a quick assessment done, start your compressions, and get that AED on right away. Shock them as soon as you can. This video is okay. Let's see if
in
it
an
does
open
a good job
pneumothorax,
representing
a
anything
penetrating
here.
injury to the chest wall allows air to enter the intrathoracic space. The loss of negative intrapleural pressure allows the lung to collapse, and ventilation of the lung is decreased. In addition, hemorrhage from the injury can accumulate in the thoracic cavity, resulting in hemothorax. Blood loss into one side of the thorax can be significant, as much as 1,500 milliliters, enough to result in the development of shock.
All right. So getting into abdominal injuries now. Abdominal injuries, again, open or closed. And here we have the potential, obviously, for far greater organs to be involved. It's very difficult for us to do a good abdominal assessment. We have to rely on our mechanism of injury, our patient's presentation, their complaints, and in order to try to decide what's going on. There is the potential, though, for some outside injuries, external injuries that we can address, such as things like an evisceration. We'll get into that in a second. So here we've got this guy. He's laying on the ground with a piece of his small intestine sticking out. That's what we would call an evisceration. Anytime we have abdominal content that is protruding from the abdominal cavity, we would consider it to be an evisceration. How would we treat this guy here? You know, obviously, to simply compress down on this open wound would not be very productive. Think about how compressed the small intestine is within the abdominal cavity. If I start to touch this and try to push it back in, what ends up happening is more and more just forces itself out. So we want to try to avoid touching it. And it's going to be tough to do if they're still actively bleeding. But in this circumstance here, what we want to do is cover this with a moist, sterile dressing. We don't want anything to dry out. And there is the potential that it would be beneficial to take something like saran wrap. And we actually do carry saran wrap on ambulances. It's nothing special. It's not medical grade. It's stuff you would buy at Walmart or Jewel. But it is considered sterile. And what we can do then is we would take that saran wrap, again, moist, sterile dressing over the top of the wound itself. Then I would take that saran wrap and I would put that either all the way around the torso if possible, or I would at least drape it over the body and tape it down. And that's really going to help more so with cleanliness than anything, because we don't want a bunch of dirt and bacteria getting into this wound. So when we're dealing with abdominal traumas, anything goes, right? Any type of complaint might be associated here. Nausea, typically associated with a lack of perfusion to the stomach. Cramps could be from anything having to do with muscle contractions, bleeding, could have to do with being dehydrated, etc. So again, assess your patient. use your decap BTLS as a memory aid, but be looking for specific things to each part of the body. All right, let's move on to bleeding control. When we're dealing with bleeding control in the abdomen, the source of the bleed may be relatively deep. Think about a stab wound, right? It could be a blood vessel that is 2-3 inches deep into the tissue. On an extremity, it's easy to see where the blood vessel is. We can apply that direct pressure there. It's a lot harder to do with abdominal injuries, though. If we can apply direct pressure and be effective, that's fine. Great. That's an easy and quick way to address the bleeding issue. However, a lot of times we're forced to pack these wounds. We'll take some type of hemostatic dressing, which are becoming more and more readily available. Essentially, it's the equivalent to what QuikClot is. QuikClot is just the brand name for a hemostatic dressing that is available on the market, but there are other brand names that are out there. And what typically happens, if you think back to your war movies, right? You see them rip open this package of powder, they dump the powder into the wound, and it clots it off and it cauterizes the injury. Well, that is certainly how they used to do it. That was the initial presentation or the initial availability for things like QuikClot. But we've gotten away from that. And now what they do is they'll take a bandage that is folded up into a Z pattern. So it might be a small 2-inch by 2-inch by half-inch thick package, and the bandage is just folded over itself in there in the shape of the Z. And they've impregnated that bandage, or in this case, really the dressing, with the hemostatic powder itself. So what we would do is open this up, we would take the dressing, and we'd begin to feed it into the wound. And yes, we'd stick our fingers straight in there and pack that wound as tight as we possibly can. As we pack that wound tight, it'll end up, the blood starts to come out, it'll activate that hemostatic powder, and it begins to develop clots, and hopefully it'll apply enough outward pressure on the bleeding vessel to get the clot to build up around the outside edge of it there and actually begin to stop the bleed. So with the eviscerations, we said not to touch, right? We know that. We know that with impaled objects, we don't remove those. The only time we can remove an impaled object is if it's impaled into the chest and we need to do compressions, or if it's impaled into the airway and impeding our ability to manage the airway. Beyond that, stabilized bulky dressings are going to be effective. If we don't have hemostatic agents, we can still use a standard dressing to pack the wound and then couple that with direct pressure. When we are using hemostatic dressings, we still need to use direct pressure in addition to that. So I would pack the wound with that Z-fold bandage, and then after that I would apply 2 solid minutes of direct pressure in order to give it time for that clot to build up.
The liver is the largest solid organ in the body and is highly vulnerable to both blunt and penetrating injury. Due to its significant vascular supply, profound hemorrhage and death from hemorrhagic shock is possible from blunt and penetrating trauma. Injuries can range from simple to severe and include simple subcapsular hematomas to expanding hematomas to lacerations to fractures to complete avulsion from the hepatic artery.
So notice in this picture here how, again, the liver and the spleen on the opposite side tend to sit beneath the rib cage. This is really something to consider. This rib cage is there to help protect that liver, if at all possible, but it doesn't always work. So here's the xiphoid process, right at the base of the sternum. You've got the rib cage that comes down. When you're doing your abdominal assessment, you shouldn't just be going back and forth down low. You need to be getting all the way up into this upside down V of the thoracic cavity and assessing up there. Assuming that the liver is injured and it's bleeding, what are some things that we'd be looking for? First of all, is the liver hollow or solid? It's a solid organ. What type of pain would we be looking for? Probably some type of dull or diffuse pain that is hard to pinpoint, but generally in this region or vicinity, they're saying, yeah, I'm having this really bad pain. We know that as the blood gets out of this area and gets away from the liver, if it comes in contact with the peritoneum, then what we might end up seeing is that sharp parietal pain where they say, okay, I can pinpoint right here, this is where it hurts on the skin. And because blood has now come in contact with the peritoneum, we know that we're going to start to feel that rigidity begin to form. So if I'm concerned about internal bleeding, obviously complaints of pain would be a big thing. Outward signs of shock could be another. Rigidity beneath the skin would be a big indicator. But the other thing here too is in order for the liver to become injured, it would have to have some type of outside trauma, right? Outside force. So again, if I were to take a baseball bat and I swing that baseball bat in and I hit the patient right here and it causes a bleed from the liver. Well, I'm also going to have broken all the blood vessels in the surface of the skin right here. So I should have quite a bit of bruising on the skin over the area of discomfort or pain. And that's it for the chest and abdominal trauma. Be sure to take time to go through my Brady Lab, read through the books. There's a lot of interactive multimedia stuff having to do with trauma. Really look into that. I also encourage you to spend some time on YouTube. Just YouTube pericardial tamponade. YouTube for tension pneumothorax, hemothorax. There's a lot of great videos and animations that help you to understand those a lot more. If you have any questions, give me a call. Thanks a lot.